welcome to the Australian Doctors Federation Let's Talk Medicine podcast number 9, why regulatory ageism must be proscribed, not prescribed.
Welcome everyone to this very important episode of Let's Talk Medicine, the Australian Doctors Federation podcast. Tonight we're going to talk about AHPRA's proposal to introduce health checks for doctors aged 70 years and over. We've assembled a very good panel to discuss this. Dr. April Armstrong is the Chair or CEO of Business for Doctors. She's a practice owner and a rural generalist and a GP obstetrician. Geoff Hawson is a retired haematologist who's the president of Australian Senior Active Doctors Association. He also has interests in palliative care. Professor Philip Morris is a psychiatrist with a specialty interest in psychiatry in older persons. He's also the president of the National Association of Practicing Psychiatrists. Dr. Chris Davis is a physician geriatrician and the treasurer of the Australian Doctors Federation. And I'm Aniello, Iannuzzi, your host. I'm the chair of the Australian Doctors Federation and I'm a rural generalist. So welcome to all of you. AHPRA and the Medical Board of Australia have put forward a proposal to do health checks for doctors aged 70 years and over. The consultation process opened on the 7th of August and it closes on the 4th of October. At this stage, not everyone in the profession is aware of the proposal. The word is getting out, so to speak. Not everyone I've spoken to around the traps is happy. In fact, most seem to be unhappy, but there are a few who like the proposal with some caveats. Let's go around the room and get initial reactions and where we should be going with this. Dr. Armstrong.
Well, I guess as the youngest person sitting at the table, I'm glad to say that the majority of people that I've worked with who are over 70 have been some of my best mentors. They hold years of experience, they have years of family life and living that we bring to the table what we need and we need to keep in our knowledge base. We're also at a time in our general practice society where the majority of GPs are in the older years and they bring that wealth of knowledge with them. Our specialists who look after aged care patients are also often within that spectrum of 65 to 70. I'm actually really sad to hear that AHPRA is targeting these wonderful doctors who have been the main people in society who have been educators. I'd like to see if there was going to be a health check on medical practitioners, it should be based on performance.
Thank you.
What AHPRA is putting up is notifications, and notifications are complaints, and they do not equal outcome. So we know that basically 6% of all doctors have a complaint made against them, but 70 to 85% of all those complaints do not lead to a regulatory outcome. And over 98% of doctors over 70 did not have a notification leading to regulatory action. So I've got a number of other things to say, but we'll get around to it a bit later.
Dr. Davis, what are your thoughts on this?
Yeah, thank you. So my thoughts really rely on my background as a geriatrician and great familiarity with all the issues mentioned in the AHPRA MBA document. Yes, of course, aging is associated with frailty across the biopsychosocial spectrum, but the great thing about interventions for older people is to keep them functioning despite that. And that's where one takes a systems approach. So AHPRA has just looked at complaints, whereas in fact there are a myriad of solutions to be found. And you rely on the system, you take a systems approach. I mean, I learned a lot about systems because I used to be a pilot, and you learned that being safe in the air is all about the right aircraft, the right avionics, the right communication systems, the right weather forecasts, not just you. And the same thing with the older doctor. To keep the older doctor functioning at their best, they need the right systems around them. So looking at the AHPRA report, there's mention, for example, that older doctors don't keep notes properly. Well, if the older doctor is actually not a touch typist, and they, for years, relied on a dictaphone to input all their patient records and had a typist helping them, now, obviously, they're not going to succeed if it's purely computer-based and you've got to be a touch typist. In fact, social media companies can tell your age from the speed at which you're typing. So that's just one example. The other sort of complaint mentioned in the AHPRA report is that older doctors have more prescribing errors. Well, the older doctor would have been brought up on things like MIMS, where you could just reach for the paper copy, check the dose, and so on. Now, if the older doctor can't access the digital pharmacopoeia, cannot reliably use the digital prescribing system, they're probably going to make errors. So this is all system errors that must be fixed before you even infer that the older doctor is failing cognitively or whatever. And so that is one aspect. The other thing, of course, is also to look at the complainants. There's a lot of ageism around. I chuckle when I think back when I was a young fellow. The old ladies, when they saw you coming on your ward round, they used to say, "Oh, he's a nice-looking fellow. He can leave his slippers under my bed at any time." And now they say, "Oh, what's he still doing here? He should have been retired years ago." So there's a lot of ageism, and that influences the threshold at which people will make complaints as well. So there's all these factors, and before you do anything, these factors can all be fixed. So you should have an occupational therapist talk to the doctor in the workplace and say, "What can I help you with?" If necessary, an occupational physician. And if your workplace is not friendly to you, then you should perhaps look at getting some legal assistance too. So that's got to be fixed. The next thing is if you're going to have a hypothesis. So clearly the medical board has a hypothesis that if you oblige older doctors to see a GP, that's going to actually reduce the complaint rate. Now, we live in an age of evidence-based medicine. I mean, the MBA is obsessed correctly about evidence-based medicine. That's why they force everyone to do CPD, which I don't agree with because we all do it innately as part of being a doctor. But that's a separate topic. But in an organization that is committed to evidence-based medicine, they don't want to know about evidence-based medicine in this matter. Because if they did, they would actually have a control group where you have normal care. In other words, that's option one. And they would have an intervention group, and then they could compare the outcomes. And also the outcome should not be complaints. You don't measure your health system by how bad it is. You measure it by how good it is. And so they should actually look at the value of older doctors, all the good that is done. And sure, subtract the complaints, if you will, but do patient satisfaction surveys and do it for both the normal control group and the intervention group. And I wouldn't be at all surprised if the control group, in other words, the group where you don't have to see your GP through mandatory demand, does a lot better, because I think you will lose very many good doctors and all the good that those senior doctors do in the mandatory group. And so if nothing else comes out of what I'm suggesting, there must be an absolute insistence that what the board is suggesting is actually done through a randomized controlled trial so that we can actually look at evidence rather than just eminence about how we're going to get the best outcomes for senior doctors and, of course, ultimately the public.
Thank you, Dr. Davis, and thank you, Dr. Armstrong. You've both raised some very good points so far, and those points have included the fact that the evidence put forward in the discussion paper by AHPRA and the medical board is, whilst it may appear to be replete with references, if you drill into those references, there's very little by way of convincing studies. There's still a lot of opinion that's proffered there rather than genuine evidence-based suggestions. A lot of it's overseas studies. A lot of it is focusing on manual dexterity of surgeons rather than doctors at large. So there are a lot of things that one must really question. Dr. Morris, what are your thoughts? You've done a lot of research into this paper and looked at the studies.
Thanks, aniello. Yes, it's very distressing. I would agree with April. You know, the performance of doctors and their referral and any sort of constraints on them should be based on performance. Performance, not on age, not on sex, not on whether you're a doctor between the ages of 35 to 45, not whether you're a male or a female or whatever else. It should be based on performance. The medical board is going away from looking at performance of doctors to trying to stigmatise a group of doctors based on age profiling. And what they've done is they've said, oh, somehow they claim that they're missing out all these doctors who are making a botch of their medical consultations with patients, and they haven't been able to identify these doctors who they claim are causing problems. And then they say, well, it's got to be the older doctors because we found out that they have a higher rate of complaints than doctors under the age of 70. But they won't tell us what the complaints are specifically and whether these complaints really lead to any danger to patients in terms of their care. That's all hidden. It's not provided information. And without that information, they really have no claim to say that just because there is a change in the rate of notifications, there is a risk to the safety. The other thing is that they use this model of profiling. We've seen this where if you don't like a particular group in society, or you think that that group has problems, you pick on one characteristic. It may be that if you're thinking about, for example, racial issues, you might find that some racial groups have more people represented in jail than other racial groups. So does that mean that you need to take aside every person of that group and say, we're going to investigate you because as a group, you people have more people in jail than others? Everyone would shout that down. That would lead to demonstrations and everything in the streets. And this is what they're doing. They're saying just because, in their view, there are some more notifications in the older doctors, therefore they're all at risk, rather than saying, as Dr. April said, identify the problems based on performance. And that's my major criticism of this thing. When you look at their data, there's no great increase substantially that's going on in notifications, even for the older doctors. There was an increase for both younger and older doctors in terms of notifications per 1,000 doctors. From 2015 to 2019, it went up around about 70%, but for both groups. Since 2019 to 2023, it's stabilised. And if you look at one of the areas that would be of concern, say the notification complaint of clinical care, for both younger and older doctors, that went up. The rate per 1,000 went up by around about 200% from 2015 to 2019. But for both groups, it declined for over 20% from 2019 to 2023. So the idea that there is a sort of escalating problem for older doctors in terms of complaints is not justified by their own data. But the bigger question is, why does the medical board decide to take one characteristic of a group and then use that to introduce a major change in policy when there can't be any other substantiation for it? That would be my concern.
That's very interesting. I also noticed in the paper that a couple of times, actually more than a couple of times, they make this assertion that somehow getting older leads to a decline in performance, and they say there is strong evidence that there is this. But if you look at the references in the papers, they don't present any evidence at all, let alone strong evidence. The best supporting evidence they presented was a US study of some outcomes in hospital, not that every doctor practices in hospital. And then even that was a very small difference, which then became irrelevant if that older doctor was considered to be a busy doctor. So there were other factors, obviously, that came into play. Dr. Armstrong, you were going to say something there?
Yeah, I was just going to point out that perhaps the perception of AHPRA is a cumulative complaints, because when you reach 75 and you've been a doctor for 40 or 50 years, the chances are you may have had more complaints than someone who's been a postgraduate doctor from 35 to 50. And I think this is something we need to look at. I would say that over the last 10 years, when I've been working with a large group of doctors, that the majority of the complaints that have been seen through MDOs, and we would need to verify this in data, but it is a little bit hard because it's that kind of secretive things that are behind closed doors. The majority of complaints have been from single, rural, isolated, overseas GPs. And that is data that we should be able to get hold of. And those complaints are far, far greater than the complaints I have ever heard of from people who are over 65 or over 70. So if we're talking about a subset of people where complaints are an issue, we need to look genuinely at patient complaints and medico complaints against medical practitioners and address the real issue and stop looking away from the elephant in the room and say, let's deal with this problem and try and help and find out why these complaints are being made. Let's not pass the buck and say it's because you guys are getting old, and when I'm getting old, somebody wants me to do a health assessment to make sure I'm fit to practice. Let's look at the complaints that are happening today.
If the medical board was serious about this, they should be releasing all the information, de-identified obviously, as to what the complaints were from what doctors in both the older and younger cohorts. And then you could actually see whether what you were saying, isolated doctors maybe that have come from other parts of the world, may have a much higher rate than other doctors. But unless they're prepared to do that, this idea that you can brand a whole group of people, whether it's age-related, sex-related, religion-related or whatever else, or colour of skin-related, is just discrimination.
I 100% agree. I think it needs to go something deeper, though. I think there needs to be a breakdown of complaints from other practitioners and a breakdown from complaints from patients.
Yeah.
I've seen too many misguided complaints against clinicians who are in competition with other practitioners, and there's this kind of underlying problem that's happening that I'm hoping that your generation never saw, but we are certainly seeing this these complaints that have been made as anonymous complaints, and I think there needs to be definition and clarity around genuine complaints versus anonymous complaints and frivolous complaints, because a frivolous complaint should not be put against the doctor, nor should an anonymous complaint without any substance as well.
One of the things the medical board published in their supporting document was to say that of the doctors who had complaints, compared the older doctors, when I say older, I mean 70 years plus, and younger doctors 69 years and below. I know it's a rather crazy way of talking about it, but the number of doctors that were somehow given some form of action by the medical board was higher in the older doctors than the younger doctors. But when I looked at their figures, the really severe forms of action was a fine, a reprimand, or a suspension of license. And the proportion of doctors who had a fine, reprimand, of suspension of practice was much higher in the younger doctors. There was no doctor over the age of 70 that had that type of sanction, but there was nearly 1% of the doctors below age 70 who'd come before the board with a notification that had that action. So the idea that the older doctors somehow are more disturbed or maybe more of a risk to the public doesn't exist even in their own data.
Do you think, Dr. Morris, that perhaps this is a bit of a grab for publicity from, getting support from the public for AHPRA, because they're not seen in a really great light? So perhaps if we look at, maybe it's the old doctors that are causing the problems, that it makes AHPRA look like it's doing something more than That's probably a very controversial thing for me to say, but are we looking at public opinion here and trying to gauge how the public are going to view AHPRA in the future?
I don't think it's necessarily that, but I do think it has something to do with public opinion. I think it's to do with the fact that they are worried that someone will come out of the woodwork and say, something bad has happened to me or one of my family members, and it's an old doctor that did it. And instead of thinking about how they can look at the whole profession, they've decided, oh, older doctors must be a risk. So let's work out a way of convincing the public that they are a risk, and then we can get involved in doing something to sort of let people know that we've done something about it. I looked at another risk group, the risk group of doctors who are practicing under the influence of alcohol and illicit drugs. If you look at the literature in Australia and overseas, it's male doctors aged 35 to 45, and they have the highest rate of substance use and alcohol use. Now, is the medical board coming out and saying that we should breathalyze male doctors before they see patients, get them to do urine drug screens every morning and have hair analysis every 3 months? You see, I mean, it's just, they've just chosen this group because they think, oh, that's maybe the way we'll get our next complaint. I don't know whether they're trying to be sort of, popular, but it's an inappropriate way of dealing with a problem.
I think it reflects a bit of a societal issue in Australia, and we also see this in our public hospitals. For those of us who work in the public hospitals, there seems to be a very low appetite for risk. They seem to go to extreme lengths to try to minimize risk and adverse events, and it's very difficult to achieve that in health because health is a complex area. It's all about human nature and human unpredictability, especially when it takes a bad turn. So no matter what we do, we're always going to get some bad outcomes. It's never going to be zero. We saw this with COVID. We see it with other things as well. It's never going to be zero. And the trouble is, you can introduce all of these other measures, and eventually they get so cumbersome that they become a distraction. And one could argue that they can potentially then lead to worse outcomes because the practitioner is so distracted by all these other things that are not to do with the patient care. That should be the first and foremost thing.
There's two issues here. One is the risk to the community of practitioners who are maybe not performing well. And the other is, claiming to the medical board, is that they're concerned about all of us as doctors. They want us to get identified early so that we can have any illnesses treated early in our lives. So the older doctors, if they get picked up for cognitive impairment, they can be given some wonderful new drug, which doesn't exist yet, unfortunately, that will turn their dementia around or something else. Dr. Hawson, who's not able to be with us right now because of technology, alerted me to this. I worked out, and he worked out, that if you multiply the number of doctors under the age of 70 by the rate per thousand of doctors who get complaints or notifications, you end up with about 5,000 notifications in 2023. The number of notifications for older doctors over 70 is 480. There's 10 times the number of notifications for doctors under the age of 70 than over the age of 70. Surely, if you're a public body looking at risk, you'd be thinking about what can we do about the massive number of notifications, if that's what you're worried about, in this other group of doctors. But they're not raising that point, and that's a real concern. The other thing is that if the medical board thinks that older doctors should be given special attention, such as having a GP visit every 3 years and cognitive testing, etc., why are they more important as human beings than younger doctors who might be having substance abuse problems or marital difficulties or are severely depressed? Surely the medical board should be enforcing its code of conduct, which is that every doctor in Australia should have their own GP and should monitor their health. I wouldn't have a problem if the medical board said that's something across the board that should be done because it's a good thing for all of us to have that, rather than focus in an age discrimination way on a small group of doctors because of some individual characteristic of their group. That really rubs me up the wrong way.
Dr. Morris, can I ask though, when you talk about the group as a whole and having these health outcomes and wanting to make sure, are we talking medical board or are we talking AHPRA? Because my understanding is that these instructions and this information was not directed from the medical board, it was an AHPRA request.
I don't know that, but the medical board's the one that's running with it, and the chair of the medical board, Dr. Tonkin, is the one that's promoting it.
That's Anne Tonkin is the director of the of AHPRA.
No, she's the chair of the Australian Medical Board.
Okay. And the Medical Board of New South Wales, which stands separate to the other medical boards from AHPRA, have we heard from them and what their intentions are, and the Health Commission, Aniello or Chris, do you know anything about those?
Well, what we can see from this document are a few things. One is that they seem to be a lot further into the planning than they'd like to make out, because on the one hand they're saying, well, we're putting this out for consultation and comment, but then on the other hand they say, well, there are three options, and for those who haven't read the paper, the options are the status quo, and the status quo is one that encourages us to have our own GPs and keep an eye on our health, etc., things that Dr. Morris has just mentioned. Option two is to have a very rigorous, expensive assessment of fitness to practice that is conducted by an occupational physician. Now, I think we all realise that finding an occupational physician in this country is pretty hard. They're pretty rare specialists.
Well, I don't know.
Where are we going to suddenly find them? And then option three is to do a GP health check, much like we do for older patients that are going for a driver's license. But then they go further and say, well, we've already decided really that we want option three, and moreover, here's a list of documents that we are going to suggest that are used to undertake option three. So I get the feeling that maybe this is fait accompli, or is that not what the feeling you get?
Oh, I would definitely say that we should not allow this to be fait accompli. I think everybody tonight has made a very strong case about the severe limitations of the consultation documents and what is proposed. And I also just wanted to get back to a point that April in particular made about the behaviour of the medical board. We know the medical board is unelected. They have people there who actually just have their pet agendas. And this has actually been an agenda that's been around for a long time and resurfaces periodically. So we don't know that it's got any mandate. I suggest also that it's a distraction, because if you talk to patients about their day-to-day experience of primary care particularly, I've never heard any of them complain that their doctor was too old. I've heard them complain that they can't access a doctor, that the consultations are too short. There's a whole lot of issues, and people are having to end up in satellite hospitals with fragmented care, spend hours and hours on ambulance ramps. State governments are busy buying ambulances and appointing paramedics because the demand for ambulance ramps is so great. So we're looking at a collapse of primary health care. A lot of it is related to the burdens and the other onerous issues that you touched on, Mr. Chairman. And so this is a nice distraction, isn't it? It's a nice distraction to say that the older doctor is the problem and this is what we're going to fix. It's an old political strategy. When you fail on everything else, whip up a storm and then try and solve a non-issue.
Yes, thank you for that. Another thing that comes to mind in all of this is it seems like it's a solution in search of a problem. Let's keep in mind we already have option one, so we have a code of conduct and ethics that we need to abide by. Keep in mind that for those of us who work in hospitals, there's a credentialing process. Keep in mind that those of us who work in private practice have to contend with accreditation. We also have AHPRA's mandatory reporting rules. So if someone's really off the rails, colleagues have an obligation to notify the board. And keep in mind that our CPD requirements have recently been increased, so much so that it's 50 hours a year. So that's over 1 week's worth of work per year we have to do mandatory training for at our own expense. So just how much is enough is a question that begs to be asked. Another interesting thing is if they were to go ahead with option 2 or option 3, namely health checks, who's to pay? Our AHPRA fees are already over $1,000 in every state except for New South Wales. It's hard to see where that money goes at the moment. It's the equivalent of a AMA fee or a college fee, and at least with the AMA and the colleges, we see what we get. We get journals, we get exams, we get education, etc. With AHPRA, we have to self-report our CPD and register for permission to work, and now they're going to impose this extra fee. In their analysis, they show, in my mind, a lack of insight, because they talk about, well, this will cost the AMA fee, which is such and such, but we anticipate that not all doctors will be charged that amount, which in a roundabout way, if you read between the lines, was, well, we're sort of expecting doctors to be bulk billed for this, but that's actually in breach of Medicare rules. So unless the government was to change the regulations like they have for driver's licenses, you can't really be bulk billing for this. This has to be fully private. April, you're an expert on Medicare.
The Medicare benefit schedule clearly states that health checks for employment basis, unless you're an unemployed person, is not able to be charged under Medicare. And the fact that Anne Tonkin doesn't even know that is quite disturbing. I am very surprised that this whole shenanigans has even come about, because can you imagine me? I'm a 54-year-old GP. Can you imagine Philip, Chris, Aniello, you coming to see me for your health check? How difficult is it going to be for me to say you are not fit for practice? That's like you're asking colleagues to turn against their mentors, the people who have stood for them, who have paved the way in medicine. You're asking the wrong people to do the wrong thing. I couldn't do it. I would really struggle to do that. I don't see one. First of all, if I didn't charge you for it, because I can't bulk bill Medicare, and I had to fill out a form for free to say you were fit for practice, my threshold to stop practice would be very, very low. But then if you made a mistake, whose fault is it?
Yes, and then how do you distinguish, say, the medical administrator versus the radiologist versus the histopathologist versus the plastic surgeon versus the emergency medicine doctor? The physical demands and the intellectual demands are different.
Well, they're outside our...
Not to say that any is better than the other, but they're different. So how are we going to do these checks?
Well, and now it's outside our scope of practice. We've already got the problem of the police department asking us to do fitness for gun licenses. Is this person psychologically fit to hold a gun license? And GPs are going, well, what's the criteria to hold a gun license? There isn't one. Now, tell us what the criteria is for each of the individual specialties. Train us up as being doctors who are going to be health professionals, screening doctors. Put the money where you want AHPRA, and then we might have a system that we can actually engage for all medical practitioners, not for people over 75, but for all medical practitioners to have a health assessment every 3 to 5 years based on a criteria that is a fit for practice for everybody. But it's a long way from that, and you'll find it very hard to find any doctors who will want to be engaged or employed in that job.
Well, I think April is absolutely correct. And I want to get back to a point that Philip made, and Philip talked about performance. And I think if we change the focus and we actually had much better measurements of performance, particularly patient satisfaction, that would actually provide a much better indicator of which doctors actually need further consideration. And I think even if you just do it every 3 to 5 years, April, you get back to the point you made. What are the criteria you're going to apply? And even worse, I mean, it's bad enough perhaps telling one of your senior colleagues that they can no longer practice. Imagine how much of a burden it is telling a 45-year-old mid-career that they need to stop practicing or get help. So I really think we've got to concentrate on the positives here. And in this day and age, a lot of hospitals do satisfaction surveys about the care, and I suspect a lot in private practice and and primary care. So we should really get back to Philip's point. It's the performance of the doctor that's the key issue, not our speculation about underlying issues.
Chris, can I make a point there, though?
Your comment there,
many patients.
Because you've misinterpreted what I said. I didn't say that. What I said was that the medical board already has within its grasp the ability to investigate doctors who are referred to it for any reason, including whether they have cognitive complaint problems, physical problems, or whatever else. What I'm suggesting is that the medical board should do its job better, and that is that they should look at the people who've got multiple complaints or serious complaints, and they should trace and follow up those people and organise for them to have more intensive medical and other forms of assessments, rather than just blanket a whole group of people based on one characteristic, age, or sex, or race, or religion. That's discrimination. Now, the other thing I want to say is that about the psychometric testing, they've said that, they want to have all the older doctors tested every 3 years with a cognitive screening test. And they indicated that they would be thinking of the MOCA, the Montreal Cognitive Screening Assessment, or the Addenbrooke's Cognitive Examination. None of these tests have been normed. In other words, they've never been tested in a group of physicians. We don't know what a score of 26 out of 30 is in a bunch of physicians compared to a score of 28 out of 30. And they've never been tested as to whether any score means anything in terms of the capacity of the physician to practice in their profession. The medical board here is not either naive or something weird is going on. They could have got easily told, if you give screening tests to physicians that have never been normed and tested in that population, they're meaningless. Even worse, all the doctors who go before their colleagues to be tested with the mini mental state or the MOCA will practice how to do it. And so the scores will be meaningless. It's crazy. It's like, as April was saying, if they're going to go down this path, they need to say, well, what do we need to do to identify whether a person or a doctor who may have diabetes or may have something else, whether that really affects their ability to practice. And that requires a huge amount of time and effort that's way beyond what the medical board can ask for. So the whole thing is impractical. But the idea that the cognitive test can somehow screen for the capacity of the doctor to do their work is garbage.
Sorry, April, go ahead.
Can I just add to that this whole process of assessing people's practice, I'd like to point out something really important. If you're asking patients, how good is your doctor? I have met many doctors who are not good doctors who the patients love. So we have to be very, very careful about patients. And most of you have worked with patients who have drug and alcohol issues or drug-seeking behaviour. And we've seen clinicians who are very much loved by their patients because they get what they want. So simply using a tool that assesses the patient's the belief or that their doctor is competent is not a good enough tool. There's a multi-source feedback tool that we use in general practice and through the RG program and AHPRA, which allows you to have 12 of your colleagues, not all medical, they have to be administration, hospital-based or clinical-based, non-clinical-based people, so colleagues you work with, someone in the community, and then I think it's 50 consecutive patients, and they take that information as well as your self-assessment And that is what we call a multi-source feedback. And I believe that is a very valuable tool that we could use every 3 to 5 years in all practice, not just general practice, but in all practice, to be able to self-reflect as well. And that should be part of our CPD that we do in the future. But that's just me throwing something out there to say that that's probably a much better idea than having a health assessment at 70 or 75.
Towards the end of their discussion paper, they also leave us in a bit of suspense. They make the suggestion that, they ask the question rather, well, if we were to go ahead with this, does the actual medical data from the health assessment stay with the assessing doctor, or does it have to go to the board? To me, that is very much a step too far, a total breach of patient confidentiality. What did the rest of you think about that?
I agree, absolutely. I mean, you wouldn't want to hand your data over to a bureaucracy, and we know also that even though they say it'll all be de-identified and it'll all be safe, look at the amount of stuff that lands up on the dark web from highly reputable companies.
But the fact that they're even asking that question is of great concern in my mind.
Well, it is, and I think we've all agreed around the table that really what is proposed in terms of the assessment process, I mean, Philip made the point about the complete invalidity of mockers and MMSEs and other tests. They certainly don't test the complexity of the clinical process. So those tools are useless in this context, and therefore they shouldn't be done. April's made the point about how extremely difficult it is to actually come up with something negative about a senior colleague, so that's not going to work. I think April touched on a solution there, that you actually do peer-reviewed assessments of your performance in small groups. It's much more workable. Rather than these mammoth things, you have small groups and you have outcomes then that say, Dr. Smith is doing okay. And that's all that we need to know.
And I think you'll find that in Australia, the psychiatrists are very strong at this. They've been doing this for a few decades now. And one of our ADF panel members, Shirley Priker.
Yeah, they're not doing it in the way
she was instrumental.
They're not doing it in the way that you're claiming. I'm involved in the Psychology of Psychiatrists, and we have peer review groups. Now, the peer review groups are there for people to discuss difficult cases and to present other information about what they're doing. They don't sit down and decide whether doctors within their group are performing well or not performing. I mean, that may be a subsidiary, secondary thing. That, let's just say someone comes along to a few meetings and they look like they're very depressed, or they look like maybe they might mention that they're drinking too much or whatever else. There might be someone who might sort of take that on board and say to them, but they're not designed to actually identify good and bad practitioners. They're designed to help practitioners talk about difficult clinical and other dilemmas.
Okay. Look, we're getting towards the end of our time for this. Are there any concluding remarks from any of you?
I think from my perspective as a younger generation doctor, not that I've been a doctor for a very long time, is I find this time a very concerning time for my colleagues who are over 70, who have been our mentors, who have been the forefathers of what we do, and who are the future of our academia. I'm very concerned that many of our regional and rural areas, and especially our remote areas where we have our older doctors, we need to rely on them still to come back and do locums. They're well loved and very, very much needed. And I would never want to have a doctor who's 70 plus simply retire because they've been told they have to do a health assessment. It really concerns me that many of the doctors who are not working for money, I mean, that's my area. I'm trying to teach people how to have enough money to retire. But guess what happens when they do? They don't retire because they love their jobs. So I want to see doctors who wish to continue practicing the art of medicine and something that they love and they're passionate about. I want them to be able to continue to do that until they no longer wish to do that, or their wife taps them on the shoulder and says, come on, honey, let's go and travel around Australia, or take some leave and spend some time with the grandkids.
Yeah, I think we've heard tonight that really there's a lot of reasons that this shouldn't go ahead in any form whatsoever. We've heard that because essentially the discussion paper is severely deficient in looking at the full range of issues. The discussion paper is severely deficient in assuming that there are tools that can be used. If the medical board and AHPRA decide it must go ahead, it can only go ahead as a randomized controlled trial. It would be profoundly dishonest if they didn't do it as part of an RCT. So I think the response from the profession must be very strong, that this unelected group, the Medical Board of Australia, really does not have a mandate for this whatsoever, and what they're proposing is certainly not best practice. So we cannot tolerate something that is not best practice, which would be a randomized controlled trial of the hypothesis, which would have to be done by a proper academic centre that is, appropriate to that. I wouldn't be surprised if a good academic centre refused to do it at all because of the points that Phillips and others have made. So this must be rejected.
Dr. Morris?
Yeah, the points I'd like to make are that I agree with Chris. If the medical board really believes that there is an issue in terms of the performance of doctors of any category, whether it's older doctors, male doctors, female doctors, doctors who are male between the age of 35 to 45 because of substance use, they should institute a proper survey looking at the outcomes in terms of the clinical practice capacity of these doctors, of all these groups. Before you do, you can't make any conclusions before you do a proper trial. And any decision about public policy change should wait until that's done in a way that's been done in a proper survey, a proper scientific survey. That's the first point. The second point is, in the meantime, the medical board should just go ahead and be a little bit more conscientious and actually chase down the doctors that are posing risks. And these are the ones that have multiple complaints. We don't know in their complaint, in their notification data, how many of those doctors have more than one complaint. And we know that some doctors have more than one complaint and they're having difficulties. They should be chasing the doctors who have serious complaints made against them and following up on those doctors before they start to use this form of profiling of groups, whether you're Muslim or Christian or Jewish or black or white or male or female or over 70 or below 70, by using some little characteristic of that group and then saying, oh, now we'll intervene with major policy changes. That is inappropriate. It leads to discrimination. It's not based on the level of fact that needs to be presented to be able to make these changes. So I agree with the other two speakers. There's definitely no evidence here that would lead to a massive change in policy. In the meantime, if they want to get more information, they should present a properly constructed proposal with evidence to support it, rather than having a thought bubble, oh, we better do something about older doctors, which I think this is what it looks like.
Well, there we are. Thank you to all of you. It's been a stimulating discussion. For those in the audience, we hope that we have presented to you an analysis of this proposal that is fair. We'd like to see all of you go to the document, make up your own minds, and most importantly, make a submission before the 4th of October, because this is a very important topic and will have major impact in terms of workforce and in terms of each individual doctor's future ability to practice. Thanks once again to the panel, and all the details and references will be in our show notes. So looking forward to the next episode of Let's Talk Medicine. Good night.
Good night.